Hi, this is John Watson again speaking on behalf of the Centers for Aging about the management of patients with dementia or Alzheimer's disease in busy primary care practices. You'll recall we took the perspective of a patient who's brought in his mother and how we might deal with that patient efficiently and effectively over the course of 3 visits, allowing the family time to use technologies for their benefit and for our efficiency and effectiveness, and allow us to see how things are going so that we can better tailor information to meet their needs. From our perspective, this slide covers the key points. What we have to do first is see if we have a diagnosis or not. And as we pointed out previously, memory impairment is a requirement plus these changes as well. There are many forms of agnosias, which means not recognizing, and the commonest is being unable to name objects. Aphasia often refers to the inability to name objects. You know what they are, but you just can't find the name. Apraxia means inability to do the things you might want to do. You want to turn over your hand from right to left or left to right, and you can't. And executive function refers, of course, to higher thought processes. We often learn of decline in executive function from family members who note that the patient who otherwise could have dealt in complex social or decision-making circumstances being now unable to do so. Once we're quite sure that we're dealing with dementia, the usual workup is limited. B12, TSH, most importantly, medication side effect review, since delirium in particular can seem dementia. And of course, in severe depression, patients will also seem to be demented. The treatment and therapeutic considerations are really quite limited. Regular exercise, eating well, reality orientation in early stages, validation therapy over time, care planning, caregiver support, and judicious use of medications. Treatment of agitation and depression has the strongest evidence that the medications actually can do some good. Memory enhancement medications are a toss-up. Probably the most challenging component of management for persons who have dementia or Alzheimer's disease is the concept of developing a care plan. It just sounds like an incredible amount of time and work. It has components from the professional, the patient, or caregiver input. It requires monitoring and reassessment of goals and problems over time, and specific designation of who does what when. A completed care plan might have these components filled in. And again, they all make sense, and we all would like to do that. But how can we possibly do that in the context of a busy office visit? Again, the answer lies in thinking about the development of a care plan as something that can occur quite well over time, particularly if the primary care physician and the caregiver take advantage of technology. Fortunately, there are now a large number of integrated tools to help caregivers and clinicians better identify the needs of the patient, tailor information based on those needs, established a care plan with priorities that can change over time as situations change, and use other tools to help in the decision-making processes that come up in caring for patients with these complex disorders. The good news is that the information links tie into those actions that an office should do but won't have the time to do in the typical constrained office setting. The most important component of care that an office practice can establish with the caregiver is an ongoing dialogue so that they're both on the same page. And the best tool for creating that dialogue is for the caregiver to complete a diary similar to that shown every week or two, the How Are Things Going diary, that tells about how the patient is doing, from 1 being, well, not too many problems, to 5, really a lot of issues, and most importantly, how the caregiver is doing. Over time, the clinician and caregiver can establish patterns whereby, for example, it makes sense if the caregiver is hitting a 4 on their inability to do well, they call the practice, for example, to avoid trouble. That's the key, that the dialogue makes sense. It desensitizes the caregiver, gives them the support they need and the feeling of support, and allows them and the clinician to communicate in a meaningful way before disasters happen. In summary, we've pointed out that the resources that most clinicians are unfamiliar with can be made available through the internet. And a lot of support can be provided by developing a living care plan that the patient's caregiver can modify over time and use a diary so that they are in touch with the office when it makes sense to avoid difficulties, and otherwise are monitoring how they're doing so that they avoid trouble before it happens. In terms of the non-drug treatments, again, we pointed out that there are really only a few things that really matter. Help with exercise, nutrition, treat agitation when necessary, and support the patient verbally using validation most of the time. Will this work in your practice? We're quite sure it will. The best way for you to test it is to go through the materials sequentially as though it were visit 1, visit 2 or phone follow-up, and visit 3. Go through the forms, see how they work. It'll only take a few minutes, and then figure out who should do what when, and how will you reinforce the patient's caregiver over time in their completion of the diary, and how will you respond to the diary or ask them to respond to the diary should a lot of 5s come up during the course of time. That's a great way to begin. Use the technology to leverage and build the dialogue. Those are the key points. Thanks very much.